Good evening, sir.
Good evening, Deepa.
Doctors, good evening. Doctors, there is a technical issue with the other two doctors, so they are just joining in a couple of minutes. So can we wait for that? Is that okay?
Definitely. Hello.
Yeah, sir. Yeah, thank you.
This is Dr. Arjun here. Of course, we'll wait for the others.
Yeah. Suresh sir. Hello.
Yeah, good evening.
Good evening, sir. Sir, Srinath here from Ciplaza. Sir,
Yeah.
Dr. Bhaskaran sir is yet to join, so he is having some technical glitches, so he will be joining in a couple of minutes. So can we start the session, sir? It's already 2:86 now.
Do we have all the other participants already?
Yeah, Arti ma'am, Dr. Arti is not there actually. Doctor had some emergency in the hospital or something, sir. So ma'am has conveyed that she could be late or she could join the meeting like that.
Mm-hmm.
So rest all are available, sir. Six doctors, Doctor.
Arjun Shankar?
Doctor is here.
Yeah, nice to meet you.
Yeah,
you can start anytime that you say.
Yeah, sir. So I request all the panelists also to switch on the camera. So it would be great, like having a face-to-face interactions with the sir. It would be great, like if you can switch on the camera. So, sir, just I will give an introduction, sir. Welcome all for the Strengthening Art Expert Summit. It's a MRF in HF Jump on Band 1. So today we have our great privilege to have moderator Dr. K Suresh, sir. The HOD Cardiology, SK Hospital, Trivandrum. So, sir, we have our expert panelist as Dr. Sajid V.S. Sir is from General Hospital, Trivandrum. Dr. Sanidha, ma'am, is physician. Dr. Arjun Shankar, sir is from St. John Hospital, Anjal. Dr. Nivya, ma'am, she is from SK Hospital itself. Dr. Deepa, ma'am, SK Hospital. Dr. Bhaskaran, sir, and Dr. Rajendran, sir, from Taluk Hospital, Parashala. So welcome all of you panelists, and sir, it's all over to you, sir, the session.
Thank you, Srinath, for that words of introduction. I think without much delay, let us start. So I've tried to do the screen sharing. Is my screen visible to all of you? Is my screen visible?
No, sir. It was sharing, but it's not visible now. I think Sarah's relogging, logged out and is relogging. Dr. Islam.
I tried to. Can somebody please do the sharing? Srinath, do you have the? Srinath, can you hear me now?
Yeah, sir. I can hear you, sir.
Yeah, there is some problem with my internet connection. It says that it is unstable, and for some reason I am not able to share the screen. So
Okay.
you have this backup with you.
Sir, give me 2 minutes time, sir. Actually, I logged in mobile. Actually, I was out with the work only. Sir, give me 2 minutes, sir. Time, sir. I'll
try once again to do the screen
yeah.
share.
Otherwise, sir, I'll just tell my coaching manager to just log in up. So just give me 2 minutes time, sir. I'll just inform him.
Let me try to do this once again.
Okay, sir. Okay, sir.
Host disabled participant screen sharing.
Host, like, can you just make sir as a admin? Can you make sir host? Hello.
Hello.
I think, sir, they have made you the host. No. Rhythm, can you make the doctor host?
If that's not possible, I think I have sent you the slides as a backup.
Yeah, sir.
From your end, you can.
Yeah, sir. Give me a minute, sir. Give me a minute, please.
Sure. Is there something coming up on the screen now?
Yes, sir. Yes, sir. Visible.
Can you see it? This is something I have started from my side. Can you just tell me whether the participants can now see your screen?
Yes, sir. We can see the slides.
Yes, sir.
Okay, thank you, Sajid, for that confirmation. So then, Srinath, can I go ahead with the presentation? What about the panelists? Shall we go ahead?
Yes, sir.
Start off? We are already 15 minutes late.
Yes, sir. Yes, sir.
Okay, then first of all, let me thank the CIPLA team for organizing this evening CME program. The focus of attention today would be on the role of mineralocorticoid receptor antagonists in the management of the heart failure conundrum. So we have a list of expert panelists. I think Dr. Aarti, first name, she is tied up with some busy engagements, but I think all the others are there. Dr. Arjun Shankar, Dr. Bhaskaran, Deepa, Dr. Divya, Dr. Rajendran, Dr. Sajit, and Dr. Sanida. I hope everyone is here. So let me get on with the presentation. The main objective of this presentation is to gain some insights on the role of mineralocorticoid receptor antagonists, its placement and utilization in heart failure management. One of the important concerns with regard to the use of MRAs is hyperkalemia. Is it really a concern in physician practice? And to, in general, create an awareness among the physicians on the role of MRAs. Now, let me start off with a brief word or two on the issue of heart failure, which is a growing menace to the adult population. If you take the prevalence of heart failure on a worldwide basis is close to 30 million people. Nearly 1 to 2% of the adult population in the developed countries have heart failure, which is more or less the same in India also. 1% of the total population, or about 8 to 10 million individuals, have this problem of heart failure. The prevalence of heart failure increases with age and it rises to more than 10% among the people more than 70 years of age. The worst thing is that 50% of the heart failure patients, if left untreated, die within 5 years. And we seldom realize it, but mortality from heart failure exceeds the cancer-related mortality. But the good thing about heart failure is that newer modalities of treatment are there. Better understanding of the pathogenesis of cardiovascular diseases has led to preventive cardiology coming up in a big way. So heart failure hopefully can be prevented. If not prevented totally, at least it can be treated better so that there is a increasing survival from heart failure. Now, based on the ejection fraction, heart failure is characterized into heart failure with reduced ejection fraction, the so-called systolic dysfunction or systolic heart failure, which we are all familiar with. That is basically an LV ejection fraction of less than 40% by echocardiography. Then you have a heart failure with preserved ejection fraction, where the ejection fraction is more than 50%. That is the so-called diastolic dysfunction, diastolic heart failure. And in between, you have a range, mid-range ejection fraction. That is, the LV ejection fraction is not so depressed, but it is not normal either. It's 40 to 50%. You will find that virtually all of the guideline-directed therapies, ACE inhibitors, ARBs, ARNIs, beta blockers, and MRAs, they all have a role in heart failure with reduced ejection fraction. But when it comes to heart failure with preserved ejection fraction, we have very concrete or solid evidence with regard to the benefits of ARBs as well as MRAs, but not so much to the same extent with ACE inhibitors, ARNIs, or beta blockers. Definitely, they do have a role. It's not to say that they don't have a role, but the evidence is less robust. Heart failure with reduced ejection fraction, these are the patients who are at the highest risk for cardiovascular events and mortality. And our treatment goals should be to reduce mortality, reduce hospitalization, improve the quality of life, and have a reassuring safety profile of the drugs used, regardless of the age and comorbidity status. And these are the 5 pillars, the so-called 5 pillars of heart failure with reduced ejection fraction therapy. One is ACE inhibitors or ARBs, the so-called RAS blockers, renin-angiotensin-aldosterone system axis blockers. Then you have the angiotensin receptor plus neprilysin inhibitor, the ARNI, which is a newer molecule which has been in use for the last probably a decade or so. Beta blockers, we are all familiar with, has been there as an integral component of heart failure treatment for quite a while. Then we have, over the last couple of years, emerging evidence with regard to the frontline use of SGLT2 inhibitors, which actually made its way into pharmacology as an anti-diabetic drug. But then this molecule quickly has been adopted by the cardiology community also in view of its very salutary effects on cardiovascular morbidity and mortality, especially in the setting of heart failure. So it's now, even in the absence of diabetes mellitus, we are using it as a heart failure treatment strategy. Then, of course, you have the molecule of today's interest, that is mineralocorticoid receptor antagonist. And these are the various trials which have supported the use of each and every one of these classes of drugs. You have the consensus trial, the SOLVE trial, the CHARM trials with regard to the use of ACE inhibitors and Arvs. I am not going into the details of all of these trials. Then, of course, after you have the beta blockers and the MRAs, you also have a couple of newer drugs, ivabradine, which is a pure heart rate modulator. There are some evidences as coming from the SHIFT trial with regards to its utility in the treatment of heart failure. And vericiguat is a newer drug which is probably not available still in India. Some trials are there with regard to its utility in heart failure. So basically, the principles and pathophysiological targets of heart failure with reduced ejection fraction therapy, 5 pathways you have to remember: the angiotensin pathway, the catecholamine pathway, the aldosterone pathway, the neprilysin pathway, and the SGLT2 pathways. And there are 5 classes of drugs. One is the Mras blockers, which block the angiotensin 2 actions. Can use either angiotensin converting enzyme inhibitors or angiotensin receptor blockers. Beta blockers, particularly the carvedilol, bisoprolol, and metoprolol succinate form, are the ones which have got the maximum effect with regard to heart failure therapy, the maximum evidence base with regard to its utility in heart failure management. Mineralocorticoid receptor antagonists, for all practical purposes, boils down to 2 molecules: the conventional age-old spironolactone, which has been there for ever since we were all students, and of course the newer selective aldosterone receptor antagonist, or eplerenone. And of course the ARNI, which is a combination of sacubitril and valsartan. Increasingly there is evidence of its frontline role in the management of heart failure, and the latest guidelines have actually given a class 1A recommendation. You can actually start, or it is really preferable, it is recommended that you start the treatment not with ACE inhibitors or ARVs, but with ARNI straight away as a de novo heart failure management measure. And of course the SGLT2 inhibitors, which is not of course the discussion today. There are a couple of additional pathways which also one has to keep in mind. One, of course, is the heart rate modulation. Anytime the heart rate is high, it's an adverse impact on survival and longevity. So you would like to keep the heart rate 70 or less than 70. And when you have already up-titrated your dose of beta blockers to its maximum, then what do you turn to? The drug that you can adopt is ivabradine, which is acting on the sinus node specifically. It acts on the funny current in the sinus node, slowing down the sinus node, bringing down the heart rate to below 70. That is supposed to improve the prognosis. Hydralazine nitrate combination, we seldom use these days unless there is a contraindication to the use of renin-angiotensin aldosterone system blockers or MRAs. If there is a contraindication, that is a kind of a scenario where this combination comes into use. It is actually a vasodilator therapy. Hydralazine is an arterial dilator, nitrate is a venodilator. Plus, of course, this new molecule vericiguat, which of course I also have only theoretical knowledge. It is a soluble guanylate cyclase stimulator. It's used in worsening heart failure. There are some trials. The Victoria trial is one. It targets the nitric oxide SGC cyclic GMP pathway and improves nitric oxide production. So the major changes in the expert consensus document decision pathway, which was updated in 2021, includes 2 medical therapies which are elevated to the front line. That is ARNI as well as SGLT2 inhibitors. And this, of course, is the 2021 ACAC update with regard to the strategy for treatment of heart failure. Step 1 would be the combination of beta blockers and RAS blockers. Increasingly, people are using ARNI as the preferred initial therapy. And ACE inhibitors or ARVs are considered only in patients with contraindications or intolerance or inaccessibility to ARNI. Once you have started the ACE inhibitor, the RAS blockers of any kind and beta blockers, plus of course diuretics if there is evidence of fluid overload or congestion like florid pulmonary edema, nasal crepitation, speedal edema, etc., then of course there is a role for diuretics. But once the fluid overload and the congestion is corrected, then probably quickly you have to reduce off the dose of diuretics. Otherwise, you will not be able to up titrate and optimize the more accepted forms of guideline-directed medical therapy, including MRAs, SGLT2 inhibitors, etc. So once you have loaded the patient with RAS blocker and beta blocker, as early as possible, you try to introduce the other two categories of drugs, MRAs and SGLT2 inhibitors, in all patients with NIHA class 2 to 4, provided the renal functions are satisfactory. There are certain cutoff values for creatinine as well as EGFR. EGFR should be more than 30 ml per minute per meter squared body surface area, and the creatinine should be less than 2.5 in males and less than 2 in females, and the potassium should be less than 5 milliequivalents per liter. This is basically almost the same that the ESC guidelines also are recommending. This is a little bit older slide, so you don't have the RD coming into the picture. Now, virtually every guideline has recommended RNs as the first line. So, in short, this is the more or less the same that we have already discussed. Now, the central role of aldosterone in the heart failure cascade, whether it is systolic heart failure or diastolic heart failure, there is reduced cardiac output, which leads to increased venous distension and increased cardiac filling pressures. The renin-angiotensin-aldosterone system gets activated, aldosterone levels increase. It translates into increased myocardial fibrosis, cardiac hypertrophy, which then results in changes in contractile function, heart failure, progressive chamber dilatation. All of these will predispose the patient to ventricular arrhythmias because they increase QT dispersion and ultimately cardiac death. There have been basically 3 trials with MRAs in heart failure. One is the RALS trial, which used spironolactone. The other 2 used eplerenone. One is the EPHYSIS trial, which was done mostly in post-myocardial infarction patients within 2 weeks of the index event. And the EMPHASIS trial, with once again with eplerenone in ischemic and non-ischemic cardiomyopathies. The primary endpoint was cardiovascular deaths and heart failure hospitalization, and also death from any cause was analyzed. And there was a very statistically significant reduction with use of both these molecules, both spironolactone as well as eplerenone. The RALS trial incorporated nearly 1,600 patients with class 3 to class 4 heart failure, included both ischemic and non-ischemic cardiomyopathies. Nearly 30% reduction in the death from any cause. Similarly, in the EPHYSIS trial, in the post-MI patients, drug being introduced within 2 weeks, there was a 13 to 15% reduction in the primary endpoint or death from any cause. And in the EMPHASIS trial also, there was a 22% reduction in death from any cause. So the same data are once again summarized here. I will skip this slide because we have already gone through these details. So what is the recommendation for MRAs? Aldosterone antagonists, receptor antagonists are recommended in patients with NIHA class 3 to 4 who have an LV ejection fraction of 35% or less, unless contraindicated, to reduce morbidity and mortality. Now, patients with NIHA class 2, also there might be a role for MRAs, but there should be a prior history of cardiovascular hospitalization or elevated plasma BNP levels, etc., to be considered for aldosterone receptor antagonists. Creatinine should be less than 2.5 in males, less than 2 in females, and potassium should be less than 5 milliequivalents per liter when you are considering initiation of mineralocorticoid receptor antagonists. And careful monitoring of potassium, renal function, and diuretic dosing should be performed both at the initiation and should be closely followed up thereafter to minimize the risk of hyperkalemia. Now, of course, I will, for the time being, take a break and hand over to the panelists for their comments. Now, I think there are certain questions that crop up into the mind. in any discussion on heart failure. So let me start with Dr. Sajid. What percentage of heart failure patients approach you in NYHA stage 2, 3, and 4? And what is your general feeling about how many heart failure patients go undiagnosed in India at an early stage? That is early stage of heart failure. And if you think that a sizable number of heart failure patients do go undiagnosed, can you think of some reasons why the diagnosis is a little bit less?
Sir, good afternoon, sir. It was a wonderful presentation. Sir, coming to the question, I think usually we will miss class stage 2 and 3. Probably now, but the reason why probably might be due to the COVID condition during the last 2 years and the restricted activity. And many of the patients may not come to the hospital with the mild symptoms. Usually they will come to the casualty or in the general hospitals with the, when they are feel more symptomatic in class 3 or 4. So usually we will definitely miss the initial stages of class 1 and 2. Usually they will be picked up by the cardiologist in the routine and CAD patients. We will miss, probably we will miss in our common general OP in stage 1 or stage 2 cases. So majority of the patient in the stage 1 and 2 will be undiagnosed in our settings, especially in Kerala also, also in the GP level and the physician level.
I do agree with you, Dr. Sajid. Perfectly, you are right actually. By and large, once heart failure is diagnosed by the clinician, not only the practicing physician, but even by the cardiologist, majority of the patients are actually in stage 3, stage 4. As you said correctly, stage 1, stage 2 is very, very difficult to diagnose, particularly in the periphery, because the symptoms might be very, very minimal. They do not come for evaluation. You might attribute the symptoms to so many other causes. So, mild symptoms, less obvious physical findings, and consequently the less early stage heart failure gets missed very much. Anybody else would like to make a comment on this issue? If not, we can go on with the next query. Dr. Arjun, did you want to make any comment?
Nothing specific, sir. I was just thinking about most likely in our country, there is a big prevalence of nutritional anemia. So people in the periphery most often attribute this to anemia. And even sometimes I've seen people coming with 10, 11 HB and saying that, okay, I've got anemia, probably that's why I'm having this heart failure. Then we'll have to sit and once we auscultate, we find some basal crabs and pedal edema, and we find that there is paroxysmal nocturnal dyspnea. Then we actually tell them and try to convince them, see, you'll have to get an echo done, you'll have to meet a cardiologist, you will have to get, and once we say that, it takes almost about 2 to 3 months for them to actually go and meet a cardiologist. So that's, I think, one of the reasons at least, which can contribute.
Thank you, Dr. Arjun. I think that brings us to the next issue. You have actually given the introduction to the diagnostic tools. Dr. Sanita is there? I think this next question is to Dr. Sanita. What are the diagnostic and prognostic tools that you use for the evaluation of heart failure patients? Is Dr. Sanita there? I think she had joined. Yes. Dr. Sanita, can you please unmute and appear on screen? I think she is logged in, but maybe some connectivity issues. Okay. Is there anyone else who would like to make any comment with regard to this?
Sir, Can I, sir?
Yes, by all means, welcome. Let us keep the ball rolling.
Sir, usually we'll start with a basic routine investigations like a hemoglobin and the importance of hemoglobin already said it. Then definitely the kidney renal function test, because we have to plan the treatment accordingly after diagnosing. Then and to rule out the other causes of this dysneonization or lipid edema and breathlessness. Then a chest X-ray and ECG. Of course, after that, echo is necessary. Then after that, the patient have evidence of coronary artery disease. Definitely a coronary angiogram would be the better investigation. And for the prognostic tool, we may somebody may have to take pro-NT, BNP, may be useful.
I think that is nice actually. In this context, actually, for the diagnosis, actually the question has got two parts: diagnostic aspect as well as prognostic aspect. Diagnostic aspect, we are thinking in terms of diagnosis, heart failure diagnosis, the major criteria, minor criteria, and things like that. The symptoms, actually, symptoms and physical findings. Symptoms like paroxysmal nocturnal dyspnea, orthopnea, then physical findings like venous congestion, elevated JVP, X-ray cardiomegaly or features of pulmonary venous hypertension, echocardiography, LV ejection fraction is a tool. The BNP is also a diagnostic tool. Very often, sometimes you find that a patient comes with dyspnea, also may not be showing anything, but the BNP is high. So when the BNP is high, we decide that the cause of the dyspnea is cardiac failure rather than anything else. So these are some of the criteria. We have all those minor criteria also. Ankle edema for some reason is included as a minor criteria. Hepatomegaly. There are so many. I'm not going to the list of all those major and the minor criteria, but the usual Framingham criteria. Plus, I think ultimately we all come to basically echocardiography and BNP parameters by which we diagnose heart failure. Now, prognosis, of course, will depend upon, as you correctly said, the etiology of the heart failure also. For instance, if it is a untreatable cause like primary pulmonary hypertension, dilated cardiomyopathy, etc., then you have a real problem in your hands. On the other hand, if it is a coronary artery disease, you diagnose by coronary angiogram some blocks which can be rectified either by angioplasty or by bypass surgery. If it is a valve problem, mitral regurgitation, aortic stenosis, which can be rectified, then the outlook is very, very good. So it partly depends upon the etiology of it. Then, of course, so as is common with a lot of cardiac situations, prognosis eventually depends upon the age of the patient, the generally speaking, the sex differences with regard to illnesses, body mass index. Obese people have a bad prognosis, coexistent kidney disease. So there are a lot of NYHA class people like you can have heart failure with NYHA 2, NYHA 3, or NYHA 4. Somebody is earlier stage of heart failure, coexistent diabetes mellitus, more severe reduction in LV ejection fraction, as you said, BNP values. All these things also come into the equation when you're thinking in terms of prognosis also. I think we can go on with the discussion. And as I said earlier, when you're using MRAs, you have to have an eye on serum potassium concentrations as well as renal functions. They manifest by a creatinine measurement or EGFR measurement. Now, Dr. Arati unfortunately is not here, so one of you will have to take up this question also. Are these parameters, do you usually check all these parameters, but this potassium level, creatinine, EGFR, etc., before and after initiating MRAs? And in case you do, for how long do you keep monitoring all these parameters? I think we had Dr. Sajit as well as Dr. Arjun contributing. Do we have one of the others can contribute? Divya, would you like to say something?
Yes, actually, these parameters should be tested before starting in the pre-initiation period itself, before starting MRIs. And after 1 week of starting, you have to monitor the renal function test and electrolytes, especially the potassium level. And you have to check periodically. You have to check every 6 months and all. You have to check renal function and electrolyte level during the course of therapy.
Okay, I think we'll go on with the presentation. This is the general recommendation and latest guidelines from the European Society of Cardiology. Heart failure with reduced ejection fraction, clearly MRI is recommended to reduce the risk of class 1 indication. And heart failure with mid-range ejection fraction, once again, there's a class 2B indication. This I think we will skip. This is basically the same 5 pillars of treatment, what are the different options and all that. Now let us come to Dr. Arjun. What percentage of patients do you use MRIs for heart failure management in your practice?
Sir, thank you for the question, sir. I usually see in about 50%. I wouldn't see more than that. Most of the time, the heart failure patients who present to us, they'll have a concurrent, they may have a concurrent chronic kidney disease, diabetic kidney disease, chronic kidney disease. And it becomes very difficult to initiate aldosterone antagonist in patients. So most often, I mean, that's why I think only 50% is reached, though it is a class 1 recommendation. So.
Any other person would like to make a comment? Dr. Sajit, Dr. Divya, Dr. Deepa? The question is, do you use it very frequently? Do you use it rather infrequently? I will agree with Dr. Arjun because the good phase of heart failure, there are a lot of concerns, hypertension, coexistent kidney disease. All these things prove to be a limitation or pull you back from using mineralocorticoid receptor antagonists. But even otherwise, I think intractable heart failure, we have been used to adding spironolactone from a long time. I think definitely there is scientific evidence for the use of eplerenone. The only problem is heart failure itself is a polypharmacy. You have so many different kinds of drugs and agents. You have ARNI, you have SGLT2 inhibitors, and eplerenone added on is going to spike the bill. The patients might find it quite unaffordable. That's all. Cost, of course, economic considerations is there, but otherwise, if forget about the economic considerations, if you ask me, definitely, I think MRIs have a clear role in the management of heart failure. But I would agree with Dr. Arjun. My own practice, and although all of us physicians, we are all aware of guidelines, we are all aware of recommendations, etc. But it's not just with us. All over the world, adherence to these kinds of treatment recommendations is only around 30 to 40%. So I think we are not very far off. In our practice also, we should be probably using MRAs in around 30% of our patients with heart failure. But that is consistent with the worldwide practice also. Dr. Divya, when would you consider starting mineralocorticoid receptor antagonists in patients with heart failure along with ACE inhibitors, ARBs, and beta blockers?
Actually, this MRIs have shown an important role in reducing the mortality, all-cause mortality, as well as this hospitalization rates and sudden cardiac death. And ideally, the recommendation is you can use MRIs, either spironolactone or eplerenone, in heart failure with a reduced ejection fraction and also with symptoms, NYHA class 2 to 4 symptoms. If the creatinine levels and eGFR are normal and there is no hyperkalemia.
I think that's a very perfect answer. I think she has addressed all the aspects. I don't really have anything more to add. You would use cortical receptor antagonists in patients with heart failure and NYHA class 2 to 4. Heart failure with reduced ejection fraction less than 35%. Already people who have been started on beta blockers and RAS blockers, and as early as it is possible. That would be the recommendation. Probably most of us would be trying to introduce MRAs a little bit later than what is recommended. Recommendation would be to start the MRAs at the time of discharge and bring it up to a decent dose with around 3 to 4 weeks later. So I think most of us would be up titrating the other classes of drugs in those periods of time, and our introduction of MRAs generally happens around 3 to 4 weeks later, although it is recommended that you try to introduce it at the around first or second week, or once the acute phase is tided over, once the intravenous diuretics and the requirements for inotropes and things like that are stabilized, then prior to hospital discharge. That is supposed to be the best recommendation, at least. Anyone else would like to have it? Please feel free to interrupt and add your comments at any time that you want to do so. Arjun, you wanted to say something?
Yes, sir. Sir, it's actually a question, sir. I was thinking, like, for those patients whom you can, we can, where the creatinine is good and the potassium is within limits. I was thinking, is it a good time to start when it's like on the third day? Third day you start a loop diuretic, and then on the third day you see the creatinine and potassium, see the trend, and then you can add a spironolactone or eplerenone, and then on 2 days later you see the trend again, and then you can discharge. Will that be a good idea, sir?
You are right. There are actually some trials. I think in this presentation also there's a passing mention of one of those trials where they have compared people in whom MRA was introduced quite early, within the first week, versus people in whom it was introduced after 7 days. And they found that the outcomes and the results were far better in those people in whom the MRA was introduced within the first week itself, not waiting up to the second week. In fact, actually, when I went through the data, I found that once eplerenone is introduced after the first week, comparison with very significant difference. Whereas within the first week versus after the first week, there's a substantial difference in terms of better outcomes. So you are right in a way. The only problem is we have so much of comorbidities along with to tackle. Very often in real world practice, it boils down to introducing it, but maybe 1 to 2 weeks after the diagnosis of heart failure.
Okay, sir. Thank you, sir.
Yeah, so this is actually the comment with regard to the time of initiation of MRAs on the risk of mortality. Use MRAs as early as possible on top of treatment with RAS blockers, beta blockers, preferably at the time of discharge after an episode of a decompensated heart failure. Following an acute fall in aldosterone in response to the administration of ACE inhibitor, levels of aldosterone start once again increasing and returning to baseline, a phenomenon known as aldosterone escape. So even when an ACE inhibitor or an ARV is given, these aldosterone levels start coming up once again. And this progressive escape of aldosterone might be contributing to the ACE inhibitor resistance. And the MRAs are probably beneficial precisely because of that fact that they are able to antagonize the deleterious effects of aldosterone. Dr. Deepa, you have been waiting for a long time, so I think this is for you. When would you prefer using eplerenone and spironolactone? Any specific patient profile? Deepa ji? Deepa, I think, we can just start hearing you.
Sir, thank you for the question, sir. And it was a wonderful presentation, wonderful discussion so far. So I think just to add to it, the preference of eplerenone over spironolactone is better in idiopathic primary hyperaldosteronism. There are studies which compare eplerenone versus spironolactone in IPH, and it was found that eplerenone scored better in terms of safety profile, especially the decrease in gynecomastia, the decrease in potassium levels. All these were better for eplerenone when compared with spironolactone. And as discussed earlier, we choose these only in preference with the renal parameters, especially the serum creatinine level, EGFR, as well as the potassium levels, and we have to monitor it carefully even when we start any of these agents.
Okay, anybody else would like to make any comments on that? I also would agree. Generally speaking, in males, when you use spironolactone, even in small doses, it is going to create a problem of gynecomastia. People are very, very concerned, and they are very, very happy when they report this to the doctor, and the doctor says it is because of the drug. You stop the drug, it will go away. True, the moment they stop, not the moment, but quickly after they stop, it all disappears, and they are very, very happy also. So that is a huge limitation of spironolactone, especially in male patients. I think even in ladies, it does cause a little bit of breast tenderness and all that. So for some reason, that is avoided by a selective aldosterone receptor antagonist like eplerenone. So male patients with heart failure, yes, I would be preferring to use spironolactone. Cost is, of course, one consideration.
Yeah.
So this is a comparison between spironolactone and eplerenone in LV systolic function in patients with chronic heart failure. The improvement in system, this is of course a study from Bangladesh. As you can see on the right hand of the slide, the various parameters like LV dimensions in systole, the end systolic volume, ejection fraction, which are all parameters of contractility. They do significantly seem better in the people who are on eplerenone. We don't have too many direct head-to-head comparisons between eplerenone and spironolactone. But this is one study which shows that head-to-head comparison vis-a-vis spironolactone, eplerenone seem to produce slightly better outcomes. Now, Dr. Rajendran, this question is to Dr. Rajendran. What percentage of heart failure patients on MRAs develop hyperkalemia? And do they require discontinuation of treatment once they develop this hyperkalemia? Your comments, please. Dr. Rajendran is there? Or? I don't think he is now. He was there at the start, but I don't think he is there now. Would anyone else like to come make any comment? What percentage of patients with heart failure? Basically, you know, whenever we are comparing trials, most of the trials are reporting that the incidence of hyperkalemia while patients are taking mineralocorticoid receptor antagonists is like 2%, 3%, 4%, and all that. But the real world situation is quite different. In real world practice, I think the incidence of hyperkalemia with MRIs is much higher, close to 10%, or sometimes even more. And once you develop, Dr. Rajendran has come back, I think. Dr. Rajendran, would you like to make a comment on this question? What percentage of heart failure patients on MRS develop hyperkalemia, and do they require discontinuation of treatment?
Sir, for your expert opinion, sir.
Yeah, Dr. Rajendra, I think once again we seem to have there must be some network problems for them. My own feeling is that yes, of course, once there is hyperkalemia, In fact, I have a couple of slides to show you about hyperkalemia and the need for down titration or stopping this treatment. You may have to stop once hyperkalemia develops. You may have to stop MRA. You may even have to stop RAS blockers for a variable length of time. You may have to, if you take totally the dosage reduction and the need for discontinuation, I think the whole thing put together would be around 50% once they develop hyperkalemia. So what can you do? And let me see whether I think along with that, there's a question to Dr. Sajit also. Sajit is very much there. So maybe you can take up these two questions, Dr. Sajit. What is your feeling on the risk of hyperkalemia, need for discontinuation of therapy? How many percentage of patients and how are these patients managed once they get into hyperkalemia?
Sir, we don't have that much experience, but usually I think it may be around, sir, explain 10 to 15%. In that case, you have to definitely hyperkalemia is lethal condition. We have to temporarily stop the drug and withdraw the ACE or ARB the patient is having, and also we have to treat hyperkalemia accordingly. But the problem is that the worsening of the heart failure also may occur in that scenario, and the patient should be admitted, and we have to monitor the renal parameters. Someday the patient may end up in renal failure. In that case, we may have to refer the patient in nephrologist for the diagnosis also. Sometimes there may be really a difficult situation, sir, to treat hyperkalemia if their patient developing while on MRI.
Anybody else? Dr. Arjun is ready to offer his opinion.
Sir, most of the time when we put MRAs along with angiotensin receptor blockers or angiotensin receptor blockers, I've encountered patients with potassium levels from 5.5 to around 6.5, sometimes even 7. But some of these patients quickly respond to antihyperkalemic measures. We have to definitely bring down the discontinue the angiotensin receptor blockers as well as the MRAs if it is beyond a particular level. If it's beyond, like, say, 6, that's what I usually put as a cutoff. But for the first, when I see that initial jump, then at least for 2 days I have to actually stop. That's what I usually do. And then I see how quickly the patient respond to initial antihyperkalemic measures, and I slowly re-add based on the potassium levels. If the potassium levels quickly drop down to less than 5, then I wait for another a couple of days, maybe a week, and then I re-add at the smallest possible dose, 25 mg spironolactone, for instance, every alternate day. And then I monitor the patient after a week to see if the potassium levels are jumping back up again. If not, then I continue the same. If yes, even after putting spironolactone every other day, if the potassium is spiking above 5.5, then I usually have to discontinue. That's usually the way I go about it, sir. I would like your comments on that.
I think yes. Most of the points have been addressed. This is one study on MRI-related hyperkalemia. Meta-analysis, they found that, as we just now said, the prevalence of hyperkalemia was close to 10%, out of which 54% was truly related to the mineralocorticoid receptor antagonists. Why they say truly related to MRI? Because this is a comparison from meta-analysis from various trials, FECs, RAWLS, emphasis, heart failure, TopCat, all those kinds of trials. And then they have compared it with the MRA with placebo also. So they found that in the placebo arm also there was a certain percentage of people who developed hyperkalemia. So they believe that 10% is the thing, and just a couple of points with regard to hyperkalemia. Patients with heart failure have recurrent hyperkalemia episodes with shorter intervals between the successive episodes. And as Dr. Arjun said, hyperkalemia leads to MRI avoidance in patients with heart failure, especially when the values keep climbing above 5 milliequivalents per liter. And hyperkalemia is increasingly a problem when renal function also decreases along with heart failure. Hyperkalemia translates into increased mortality, and very often down titration is required. Down titration or stopping is needed up to the extent of 50%. And interestingly, people who are on sacubitril/valsartan combination instead of ACE inhibitors or ARBs, the risk of hyperkalemia is a little bit less as compared to ACE inhibitors or ARBs. Now, this is just a quick understanding. Normokalemia is defined as potassium of 3.5 to 5. Below 3.5, hypokalemia. Above 5 is hyperkalemia. 5 to 5.5 mild, 5.5 to 6 moderate, and more than 6 is severe. So, Dr. Bhaskaran, the question is for your clinical practice. What is the preferred dose of MRA and how is dose titration carried out in your practice? Is Dr. Bhaskaran there? Dr. Bhaskaran is there or not there? Dr. Bhaskaran is logged in, but I don't see any. Can you people hear him, or there's some problem with my net?
Hello.
Hello. Yes.
Sir, I think some network connecting issue in Dr. Bhaskaran.
Okay. This is actually when there is hyperkalemia, how do you adjust the dose? I think this is a little bit complex slide. Let me see whether, yes. Basically, you have to check the renal function and the electrolytes. Start with a low dose of eplerenone 25 milligram with a target dose of 50 milligram once a day. Dose up titration you can consider once every 4 weeks. It is recommended that you check the blood biochemistry at 1 week after starting MRA and 4 weeks. Whether you start or whether you increase the dose, you do this recheck at 1 week and 4 weeks after starting or increasing the dose. After that, you check at 8 weeks, 12 weeks, then 6 months, 9 months, 12 months, and it's recommended after the first year, you keep still checking it every 4 months. If the potassium rises above 5.5, then you have to reduce the dose to half and monitor the blood chemistry more closely. And if potassium rises to more than 6, then you have to stop MRA immediately. This is actually the dosage adjustment proposal. If you start with spironolactone dose of 25 milligram per day or eplerenone 25 or 50 milligram per day, and if the EGFR is low, there is some concern with the EGFR, then maybe you can start with half the dose, that is spironolactone 25 milligram every other day or eplerenone 25 milligram per day. That would be your step 1. And if after that 1 week or later you check the blood chemistry, if the serum potassium is less than 4, you can increase the dose. If it is 4 to 5.4, no adjustment is required, you continue the same dose. If the potassium is 5.5 to 5.9, you have to decrease the dose. So if the spironolactone dose is 50 milligram per day, reduce it to 25 milligram per day. If it is 25 milligram per day, you reduce it to 25 milligram alternate days. like that. You just come down by a step. And if the potassium is more than 6, as Dr. Arjun was saying, then I think you have to stop the MRA treatment, reassess the potassium levels after 1 week. And if the potassium levels have dropped to below 6 and you still feel that you have to reintroduce MRA, then probably you may have to use a potassium binding agent also. Dr. Arjun, in clinical practice, how early are MRAs initiated for the management of heart failure patients?
Thank you,
I think we have just briefly mentioned this already.
We have mentioned this.
Can you just quickly summarize your earlier observation?
Like what we previously mentioned, sir, the ideal time would be at the time of discharge or within 7 days. That would be the ideal time, but most often it's not really possible. So, like you said, it's usually initiated after 1 to 2 weeks, probably at the time of next review. But ideal time would be within the first 7 days.
This is actually that trial which I was referring to, timing of eplerenone initiation and outcomes in heart failure after the MI, the EPHYSIS or the post-myocardial infarction trial. So earlier administration of eplerenone, 3 to 7 days, improved outcomes in patients with LV systolic dysfunction and heart failure post-myocardial infarction patient. There was a 31% reduction in all-cause mortality and a 34% reduction in sudden cardiac death when eplerenone was introduced earlier than 7 days as compared to after 7 days in comparison with placebo. So that was a trial which I was mentioning earlier. I think let us quickly wind up because we have been on stage for nearly 1 hour now. Any one of you can answer this question. I think Dr. Bhaskar has got some logging in issues. So the question is open to all of you. At what stage of heart failure, diuretics and MRAs both are needed? Somebody?
I'm sorry to keep keep answering. May I answer, sir? Hello?
I think that overall there is some kind of a network issue. I was just wondering in between whether it is an issue with me because Dr. Arjun is, he's audible, but I can just about hear you.
Okay, sir. Am I audible, sir, right now?
Yeah, would you like to say at what stage would you consider using diuretics as well as MRAs?
Sir, diuretics, the loop diuretics actually, when combined with the MRAs, I believe give a very stable potassium levels. Potassium, the hyperkalemia and hypokalemia can be balanced. So in my clinical practice, from the seniors that I have observed, they usually add a loop diuretic along with Cortical, spironolactone, sir. So it's usually added together. That's what I've found mostly in my clinical practice. They add on with the initial part would be loop diuretics anyways, and then we titrate and then we clear the lungs, and then we finally add on an MRA to stabilize the potassium levels. So that is one thing which I've observed, sir.
One of the issues with regard to diuretics, you see, unlike the beta blockers, Mras blockers, ARNI, SGLT2 inhibitors, MRAs, etc., and diuretics are actually indicated when there is fluid overload, when there are symptoms of pulmonary edema, pedal edema, all kinds of fluid overload situations, you use diuretics. Once you get rid of the congestion part of it, then thereafter, long-term treatment of heart failure, diuretics will come much lower down on the list. In fact, the strategy would be, if you are hampered by hypotension, stop the diuretics first and step up the ACE inhibitors or ARNI or whatever. Because very often you have a patient with a systolic blood pressure of 90, and that 90 is because the myocardium is not strong enough to generate a higher pressure because of the heart failure. So what can you do? You cannot give, very often the two factors that limit you from up titrating the dose of the guideline directed medical therapies is either the use of diuretic or the use of nitrates unnecessarily. So if you stop nitrates, if you stop diuretics, then you will probably be able to up titrate the dose of the other evidence-based therapies, which are proven to improve the mortality survival in patients with heart failure. Diuretics, no doubt, are very, very important. When the person comes with acute heart failure and is intensely dyspneic, there is no question, it is life-saving. But when we are talking about mortality reduction, we are not talking about that kind of an acute life-saving situation where you are using intravenous diuretics, but a long-term maintenance therapy with diuretics. There, probably, if at all any diuretic has got a role, it is torsemide only. Most of the other diuretics do not have that kind of a impact on mortality reduction. I think we are coming to the end of our questions. Which one of these would be your preferred choice of combination therapy? Torsemide with alone, torsemide with eplerenone, spironolactone alone, or spironolactone with torsemide? What is in your practice? Anyway, a question open for everyone. Dr. Divya, Dr. Sajid. There is no. Which one are you more frequently using? That's all, I think.
Maybe eplerenone, but coming to the force factor, usually we'll go for the spironolactone. Sir pointed out the patient having evidence of fluid overload, then maybe in the initial stages, till the patient begins stabilized, combination of spironolactone with the torsemide.
Dr. Deva, you would like to make any comments?
If cost is not a concern, combination will be a better choice.
Which one?
Eplerenone torsemide will be a better choice if cost is not a concern.
Yeah, that's right. Correct.
Cost is a concern, definitely we will go for spironolactone torsemide.
Divya?
Yes, sir. I also agree with Diba madam. If the cost is not a concern, definitely eplerenone plus torsemide is the drug of choice.
I think most of us would definitely, as correctly pointed out by Dr. Deepa, Dr. Divya, and all the other panelists, we would opt for a combination of torsemide plus eplerenone in the acute phase when there is fluid congestion and all that. And once that acute fluid overload status is corrected, maybe slightly tailor down the need for torsemide and try to maintain on eplerenone or the Mras alone. That would be our basic strategy. And is there any other situation where you would be using MRAs in your practice other than heart failure? One other situation where I can think of where you have a role for MRA is resistant hypertension. Actually, we know that by definition, resistant hypertension is 3 drugs which include a diuretic in a proper dosing schedule. And one of the preferred strategies in the management of a resistant hypertension is to add on a cortical receptor antagonist. That is one situation where I think I would be using MRAs. But otherwise, I don't see any post-myocardial infarction patients probably. But then only if the LV injection fraction is low. Otherwise, I don't think there is a definite recommendation to use MRAs in order to prevent myocardial fibrosis and ventricular remodeling and things like that. Any comments from the panelists? Okay, then I think we will just wind up with the last question, which the company people would like you to suggest. What scientific initiatives would you suggest to CIPLA for increasing awareness amongst the clinical practitioners? Would you like to make any recommendations to the CIPLA team in their efforts to increase the awareness amongst us?
Okay.
with regard to MRIs.
May I speak, sir?
Yes, by all means.
Okay. Actually, the perfect example is this. Any recommendations, guidelines you see, it will be superseded by an expert panelist, expert person, expert sitting whom you can relate to, who is from your same region, who can talk to you regarding what is clinical practice is. I'm referring to you, sir, actually. Hearing that gives us a lot of awareness, gives us a lot of how we can incorporate all those all your experience into our practice. So such discussions would help a lot more. People from our own region, expert from our own region, a discussion amongst our own people, that will help give us a better insight into how to treat heart failure and hypertension in our own people. Rather than guidelines which is made elsewhere internationally. That may not be of much use. Such discussions will help a lot. Thank you, sir.
Perfect, absolutely on the dot. You have made a very, very, very pertinent comment and a very valuable suggestion to the CIPLA team. I do agree with you. Even I do learn by listening to the experts, seniors in our profession from our own country and our own practice, because they know much more about, they do see such large numbers of patients in contrast to these people who make all the guidelines based on data, which are at least sometimes not very relevant to our country. Very true.
Sir, anyways, sir, Arjun sir, what Arjun sir told, this is the concept behind this meeting also. So, sir, from CIPLA, I would like to convey that in coming time, we would like to host these kind of meetings with the expert panelist and a moderator who can talk to the doctor from the same region about his experience, and doctors also can share their views on the MRAs and all. We would like to organize more meetings in coming times, sir. So it would be great having all you here. So I really take sir's opinion and we will be taking it forward, sir.
Thank you. Thank you very much. I think, can we wind up the session?
Yeah, sir. Yeah, sir. Anyways,
on my behalf, I would like to thank all the panelists who have contributed so much. Dr. Arjun Shankar, Dr. Sajid, Dr. Deepa Ji, Dr. Divya K. And did anybody else make any comments? I think they were present, but I think could not log in because of some network issues. Anyway, thanks to Dr. Sanita, Dr. Rajendran, and Dr. Bhaskaran also for being part of this program. Thanks very much. Thanks to CIPLA team also for organizing this meeting. Thank you very much. Over to you, Srinath.
Yeah, sir. Thank you so much, sir. It's been a great discussion, sir. I came across many meetings across the country, sir, but no meeting has been so much interactive. Anyways, I thank all the panelists and Suresh, sir, especially for conducting and being a part of this meeting. And I, from CIPLA, I assure, sir, more meetings like this expert summit will be conducted across the state and across the doctors, so that it would be, as Arjun sir said, it would be a more interactive rather than following the international guidelines. More than international guidelines, clinical experience, our doctor says it would be more valued. And sir, I take this as a big opportunity to thank everyone who attended this meeting, sir. Thank you so much and good night, sir.
Thank you very much. Good night.
Good night, sir. Good night.
Thank you. Thank you. Thank you.